Okay, so I just have to share with you, we found, I sent you a remind, but we found the abdomen. It's saved to the computer. We didn't find it. One of the student workers who works in CSTL found it. We're so happy.
So if you're in a different semester watching this, because you're probably going to watch this next semester and you'll have no idea what we're talking about. We've had some technical difficulties with the videos, but we have got them worked out, so yay.
We are so excited.
Prayer of Thanksgiving.
Yes.
Okay.
So now we're going to talk about female genitalia assessment, and I don't know what I'm more excited about, that we have all of our technical issues resolved, or that I get to talk about female genitalia assessment.
That is sort of Bobby's specialty.
When I first got out of nurse practitioner school, I went to work in the student health center here at this university when the University Health Center owned the campus clinic. And so I did a lot of well woman exams, and it sort of was my bread and butter for a lot of years. I was also known as the STD queen. I had a tiara. You have to be famous for something. I saw a lot of STDs. But I did learn to love women's health. I think I made a difference in the lives of a lot of young women, and I enjoyed it.
Absolutely.
And so, anatomy and physiology review, you can review the anatomy. If you have not looked at this in a while, we're going to look at several pictures. Here's another representation of the female genitalia. Next, we have a side view of the female genitalia so that you can see the anatomy from the lateral perspective instead of the AP perspective. And then here is an AP cross section so that you can sort of get an appreciation for the uterus and the ovaries and the fallopian tubes and the broad ligament and the cervical canal and the vaginal vault. One more picture, and then we'll sort of break it down part by part. The mons pubis, that's that pad of adipose tissue that covers the symphysis pubis. If you're thin and you lay on a carpeted or a hard wooden floor, you can sometimes feel that bony prominence. Sometimes it's covered with hair, sometimes it's not. Most cases it's not. I'll never forget the first time I ever saw a shaved female mons pubis. I thought it looked naked, and now I will tell you that when I see a mons pubis with hair, it's sort of like, oh,
we don't see that very often.
Yes, so
just cultural things.
Well, and years ago I wanted to do a study, just a descriptional study about why did you remove your pubic hair. Somebody said that they thought it was correlated with sort of the greater availability of pornographic movies and videos, that a lot of pornography stars remove their pubic hair, and so that it sort of became the culture because of that.
Interesting. I did not know that.
So I never did the study, so I don't know.
One of my collaborators says, the hair is there for a reason. You're not supposed to take it away. He's an older gentleman. Very, very nice. But yeah, he always has frustration when he has to do female exams
on someone without hair.
Yeah.
Exactly. So the labia majora are those large, some people call them lips of the vaginal vault, and then the labia minora are on the inside of the majora. You can also see in this image the clitoral hood and the glands of the clitoris. That's the female equivalent to the head of the male penis. And so there's another picture of the clitoris. And so this is the primary sexual excitement center for females. And if you'll recall, we are all not made just like the books or the graphic images represent us to be. And so some women will tell you that they never really achieve sexual excitement during vaginal intercourse. And if their clitoris isn't being stimulated during vaginal intercourse, that would explain why that tissue isn't being stimulated. The vestibule, that area close by the labia minora, and it basically has 6 openings that you'll want to think about. The urethra, the vagina, the Bartholin glands, 2 ducts of the Bartholin glands, and the Skene glands, 2 ducts for those. So there are those Skene ducts. They drain the urethral glands. And then here is the vaginal opening. We call this a dark gaping hole. That's sort of what it is. The hymen surrounds that vaginal orifice. It's a connective tissue that may be circular, crescent-shaped, or fimbrated. The Bartholin gland ducts or tags are located on either side of the vaginal orifice, I think about somewhere between 4 and 5 and 7 and 8 o'clock. They secrete mucus during sexual arousal, and so this is what helps to provide vaginal moisture during sexual activity. The vagina is a musculomembranous tube. It inclines posteriorly at about a 45-degree angle, so sort of toward the small of your back. It is separated anteriorly by the bladder and the urethra, and that's the vesicovaginal septum, and it's separated posteriorly by the rectum, and that's the rectovaginal septum.
I think it's important to remember that 45-degree angle. When you think about going to do an exam, you're going to go slightly down with your speculum when you go in, because otherwise, if you're going in the wrong direction, it's going to be uncomfortable. You need to know.
Yeah, so you sort of want to angle that speculum toward the small of their back.
You got it.
The upper end of the vagina is actually a blind vault, and the cervix, the distal portion of the uterus, protrudes into that vaginal vault. The purpose of your vagina is to carry menstrual flow to the outside world. It is the terminal portion of the birth canal, and it is the receptive organ for the penis and or other foreign objects during sexual activity or experiences.
The uterus sits in the pelvic cavity between the bladder and the rectum, and it's an inverted pear-shaped muscular organ covered by peritoneum and lined by endometrium, which is what is shed during menstruation. A flattened anterior posterior usually inclines at 45-degree angle, and may be anteverted or anteflexed forward, retroverted or retroflexed backward toward the rectum. So it can be either or. Usually it's always naturally flexed slightly forward. I think 20% of women have retroflexed, where it's flexed backwards, and that's actually how mine is. They always tell me I have a hard time finding my cervix because it's retroflexed.
Again, I think that's just none of us are exactly like the book, and
Yes.
so there's this graphic representation of how things ought to be, and then there's real life. And I think probably as acute care nurses, you can relate to that most commonly, trying to find the urethra during Foley catheterization. You know, we know where it's supposed to be, and then we know where we sometimes find it.
You got it.
The uterus, the corpus of the uterus consists of the fundus, and then the main portion or body, and then the isthmus is that lower portion adjacent to the cervix. The cervix extends from the isthmus into the vagina. That's the part we can actually see, and it's comprised of ectocervical cells and endocervical cells, and they join at what's known as the squamocolumnar junction, also known as the transformation zone. And that's the junction that is ever-changing and ever susceptible to viruses, particularly human papilloma virus, that is the primary cause of cervical cancer.
Got it. So whenever we talk about performing a pap smear, we want to make sure that we get cells from the transformation zone.
I also think about in younger women, that transformation zone is often visible, and then as we age, it involutes. And so the younger you are, oftentimes the more promiscuous you are, and the greater the likelihood you have HPV exposure, whereas older women are less susceptible because it's involuted and a little harder for that virus to get there.
I'm not saying that older women aren't promiscuous, especially somewhat.
Well, and I think that we all,
Culture.
well, and elderly women, I think that, as a general rule, I think we think that the older you get, the less promiscuous you tend to be, but that's not true. We worry particularly, again, we're seeing this bimodal occurrence of STDs in young women and in older women, and I tend to think about sort of that retired population in Florida,
Yes.
if you will. And for a variety of reasons, I think that are different from the younger woman, but older women tend not to remarry for financial reasons, or their children don't want them to remarry
Their
relative to
inheritance.
inheritance things, and so they have friends with benefits.
Yeah.
They really do. So here's the transformation zone. You can see this ectocervix and then the endocervix, and this is the area where it's critical that you collect cells during a pap smear. Another, you can see this transformation zone very beautifully. And when I do a pap smear on a young woman, I think about the walls of the vagina are very rugated. So I think if you take a cobblestone street, if you took about 20 feet of a cobblestone street, and if it were flexible and you scrunched it all up together into about 20 inches, that's what the walls of the vagina look like. And you know you're at the cervix when you see this slick, glossy surface. And so you can just see how slick and glossy that looks like, and you can see the difference in texture here in that vaginal vault.
Yeah. And you can often like trap it in your speculum. And even sometimes when you pull the speculum out, you kind of got it trapped in there, almost open it a little bit wider to get it back around from it.
So in pregnancy in young girls, we talked about this os is external, and if you can see it, it's called ectropion. And again, that leads you to greater susceptibility toward cancer if you're exposed to human papillomavirus. The term friability is the term that we use, that if you collect cells from that cervix and it bleeds, it's not a bad thing, it's just a thing, but the term is friability, sort of fragile, if you will. Our fallopian tubes extend from the upper portion of the cervix to the ovaries on either side.
Our ovaries are a pair of oval organs resting on the lateral pelvic at all at the level of the anterior superior iliac spine, approximately 3 centimeters long and 2 centimeters wide, and about 1 to 1.5 centimeters thick. They're almond-shaped and secrete estrogen, progesterone, and testosterone. They're palpable in only about 50% of reproductive age women.
If I palpate an ovary, I'm concerned
about it.
Yes.
Absolutely. Adnexa is the ovaries, tubes, and supporting tissue. So you palpate, you do, after we do the speculum exam, we'll talk to you about a bimanual exam where you palpate for the adnexa, which includes, again, all those things.
So, yes, and you have somewhat of this picture in your textbook, but the one you have on your screen is a better representation of the pelvic, inferior view of the pelvic muscles. So here's some terms, and some of these terms are defined in your book on page 543, but you need to know the definition of all of these terms. So if they're not terms that are familiar with you, this might be a great flashcard time, or
whatever way you
want to learn those terms, but you have to know the meaning of those terms. So let's talk a little bit about menopause. The typical age is somewhere between 48 and 55, average age being 51, and menopause is diagnosed retrospectively, meaning that you have to be without a period for 12 months before you can certifiably say you have hit menopause. And so if you go without a period for 6 months and then you have another one, you have to start over in the counting process.
Basically, it's not uncommon. At that point, menses become very irregular, kind of sporadic, and stretched out longer than normal. Sometimes they, can go 6 months without a period, and then all of a sudden you have 2 in 1 month, and then they don't have any again for a year. So it's kind of erratic.
And part of what happens during that menopausal process is our ovaries decline and then totally cease producing estradiol and progestin. So what happens is we have an increase in our FSH and our LH during that time period. And so I think of this sort of like the thyroid gland, where there's that inverse relationship. As long as I'm producing estrogen and progestin, my FSH and my LH stay in check. When I stop producing, my FSH and my LH increase to stimulate that ovary. I don't typically draw FSH and LH values because I can tell you that if a woman comes in and tells me she's having hot flashes, mood swings, irritability, and night sweats, and she can go from 0 to homicidal in 3 seconds flat, I'm not about to tell her, oh, well, I drew these labs and you're not menopausal. No. So I just think it's sort of a waste of money. I'm going to treat them anyway. I don't care what their lab values say, so I don't routinely draw them. Now, perhaps if I saw a 35-year-old woman with those symptoms and I was concerned about premature ovarian failure, I might draw them then. But in somebody in this 48 to 55-year-old age range, unless they just really want some sort of confirmation, I typically don't draw them. So hot flashes, mood swings, irritability, and night sweats. We also know that estrogen contributes to bone health. So when we lose estrogen, we lose bone health.
Yes.
We can also see an increase in our low-density lipoproteins and vulvovaginal atrophy. So estrogen helps promote vaginal health, and without it, it deteriorates.
Yes. That's why you actually probably have seen commercials on about pain. You don't have, I think how they advertise is you don't have to have painful intercourse after menopause, whatever product is they're advertising.
Right.
But again, that the estrogen loss leads to that atrophy and then dyspareunia or painful intercourse.
You'll learn that term. You probably didn't really worry about that in acute care. Dyspareunia. You weren't worrying about people's sexual health, and you will do that a lot in primary care. My husband says that he sometimes thinks I have a neon sign across my forehead that says, "Tell me all your weird problems," because I seem to be a magnet for that. I don't know. He said, "Bobby, I really think you have a sign that some people can just see, because most people don't talk about that stuff." So menstrual history. How old were you when you had your first menstrual cycle? When did you have your last menstrual cycle? How often do you have a cycle? How long do they last? How much flow do you have? Any associated symptoms or any symptoms of menopause yet?
Sexual history, are they sexually active with males, females, or both? And you ask that to every client. We've talked about this in previous lectures, but just remember that. The frequency of intercourse. Are you satisfied with the frequency of intercourse? Are you dissatisfied with that, and why? Is there any pain? Is there any difficulty with vaginal lubrication, orgasms, level of satisfaction? What was the age of their first intercourse and number of sexual partners? Any history of STIs, HIV, hepatitis, and any history of trauma or abuse? Have they been raped? Contraception, are they satisfied with their contraception option that they are choosing? Do they need something? Do they need counseling? Do they have questions?
Sad but true. There are people in Cape Girardeau who sell their friends for money for drugs. And so you may see women who are in a relationship with a man who they actually prostitute them for money. So I think sometimes we think about, oh, well, that wouldn't happen here. But it does happen here. It is. It's pitiful. And sometimes women are willing to exit that situation, and sometimes they're not. But it happens. So you just can't overlook that. Teenagers, it's important that you talk to them alone. It's important that you remind them.
If you want to get accurate information, parents in the room is just not helpful for that. There are a few, I guess, that are an exception to that. They feel as open with their parents, but a lot of them won't. So
I start prepping my parents at about the age of 10 or 11, and I tell them, well, I actually start prepping much younger. When your child is about 10 or 11, I'm going to start doing part of the visit by themselves. They need to learn how to do this before they go to college, and so that's just how we do it. And then I bring them in later. But I always remind the patient that whatever you tell me, unless you're at risk of hurting yourself or somebody else, is confidential. Some of my patients your age have started having sex, and I was just curious if you've started having sex.
And one thing she didn't mention, but it's there in the top bullet. Start talking about other things first. Never just cut right to the chase when it comes to these kind of things, because then you're really going to not get any response. But talk to them about school, help develop that rapport, and then you can kind of normalize the topic by saying, yeah, a lot of my patients your age, and asking them, then, have you had sex, or have you, experimented?
Or I've seen a lot of patients lately who have been really concerned about sexually transmitted diseases. Do you have any questions about that?
Yeah, so that's a good way for them to say that or ask that. I feel comfortable asking.
I think about
defining sex.
Defining sex.
Yeah.
I can't tell you how many times I saw women with genital warts who were insistent that they had not been sexually active. And Bill Clinton said he hadn't been sexually active either, but at the end of the day, I think we all know it's fairly common knowledge that he was having oral sex with Monica Lewinsky. And so oral sex can transmit sexually transmitted infections. I think they ought to be called intimately transmitted infections.
ITI.
But they're not. And so it's real important that you identify how they define sex, because they probably perceive everything short of pure penile vaginal penetration as not being sexually active. Like if I'm not doing something that is confirmatory to get me pregnant, then I'm not having sex.
There are some young girls that also think anal sex is not sex.
Because it can't get them pregnant.
Exactly.
Absolutely.
So, good time to educate.
So, adults, you want to make sure that you give them an explanation about what you're going to do. So, I'm going to take a few minutes to ask you some very direct and personal questions. I know this may be uncomfortable, but it helps provide us with an idea of some of your health risks and what we might need to focus on to help you be as healthy as possible.
Yeah, I ask these questions to all of my patients, regardless of age or marital status, and they are just as important as other questions about your physical health. So, again, normalizing that so that they feel comfortable to discuss it. The 5 Ps.
Yeah, some governmental agencies recommend that you think about the 5 Ps. So you think about partners, how many, what type, the past 2 months, the past 12 months, what are you doing to prevent pregnancies, what are you doing to protect against STDs, what sort of practices do you engage in, and what's your past history of STDs.
History.
Yes.
Additional questions to identify HIV and hepatitis risk. Have you or any of your partners ever injected drugs? It's actually one of the bigger causes of hepatitis than even sexual related. So hepatitis C especially, any prison tattoos or injection of drugs, IV drug use. Have you or any of your partners had sex with prostitutes? Obviously a greater risk there. Have you ever gotten hepatitis B vaccination and all 3 doses of it? Have you ever gotten hepatitis A vaccine, which is 2 doses? And have you ever been tested for HIV, that virus that causes AIDS?
And is there anything else that you think I need to know?
Always ask that, because there's always a possibility that you didn't ask something
That they're concerned about or that they have a question about?
you can never predict.
Have you ever had a pelvic exam? Do you understand the difference between a pap smear and a pelvic exam?
There is a difference. A
And
lot
so-
of people don't.
If you present to the emergency department with lower abdominal pain and you're female, chances are you're going to get a pelvic exam. In all likelihood and probability,
Not even with that.
they're not going to do a PAP. So a PAP is part of a pelvic exam. A pelvic exam is whereby we evaluate the integrity of your pelvis with a speculum. But most women think once the speculum goes in that they've had a PAP smear, and that's not true.
No. It's kind of like the venipuncture and the actual labs that were drawn. So yeah, you had venipuncture, so you thought you got a CBC, but you didn't order the CBC. Instead, you did a CMP or you just, whatever.
You did lipids.
You did lipids, but, they assumed just because that you were there, you got what you needed, and that's not necessarily the case. Cleansing routines, are they douchey?
Please don't.
Don't. It's never recommended. Use of any vaginal hygiene products, again, not necessary. It cleans itself. It's designed to do that. It doesn't need anything else other than really just water.
Soap and water.
Soap and water exteriorly.
Yes. Douching actually wipes away all the normal flora, and so it allows the harmful flora to overgrow.
Yes.
And then, do you have a history of vaginal infections? What about a history of urinary tract infections? Contraceptive methods used, failures, successes, misconceptions. Oh, my aunt, when she's been dead now for 30 years, but she took birth control pills and she had a stroke. And well, the birth control pills of 30 years ago are not the same as the birth control pills we have now.
Mm-hmm.
It's sort of like if you've ever seen that patient that their uncle died having their gallbladder removed, and so everybody in the family is going to avoid to have a cholecystectomy at all costs, and so it's like, well, that was 50 years ago. Things are a little different now.
Pregnancy, what is their gravida status? Gravida is for the number of pregnancies. How many times have they been pregnant? Parity is the outcomes of the pregnancy. And then you have full-term premature abortion or living children.
Sometimes you'll see that F as a T, just meaning term.
Term. Yeah.
And P, premature, A, abortion. And we talked about this before, when you talk about abortion in our world, that's
Yes.
either a spontaneous or an induced abortion, but lay public.
That you just think abortion is elective, but a miscarriage is also an abortion.
Any complications associated with their pregnancy? Postpartum depression.
Very real. Very prevalent.
Very prevalent, very prevalent. And so when they present today, are they here for a routine screening and evaluation? Have they had some abnormal bleeding or abnormal discharge, some pain?
So pain could be an ectopic pregnancy, it could be ovarian torsion, appendicitis, it could be a GI issue, otherwise urinary, ovarian cysts, metal smirch, which is the pain that's associated with ovulation, ruptured ovarian cyst. It could be an abscess, endometriosis, fibroids, abuse, or pelvic floor spasm. There's so many different things that can contribute to pain.
So we talked about urinary symptoms, either infection or incontinence. I think we're seeing a lot more people present and being forthcoming about incontinence because of direct-to-consumer advertising. They now are aware there's something to do for that. Lumps or bumps, could it be a sexually transmitted infection? Do they think they're pregnant? They are convinced, and we talked about this in class, that home pregnancy tests are not as sensitive or specific as what we have in the office, and they are, but contraception, maybe they want to be on a contraceptive method, or they want to change contraceptive methods, or maybe they think they're menopausal. So basic components of a periodic well-woman visit. You're going to get a history, you're going to do a physical exam, and at a minimum you want to do height and weight, a set of vital signs, evaluate their neck and their breasts, neck for thyroid particularly, give their abdomen an exam, look at their skin, and do a pelvic exam. It's recommended if they're over 40 to look at their oral cavity and their axillary region for cancer, basically.
Laboratory testing that are common during a well-woman visit. As appropriate, you're going to do cervical cytology and screening for STIs, and so we'll go through the pap smear recommendations or guidelines later. If they're 19 through 39, they get a TSH if they have increased risk. So if they have family history of hypothyroidism, that's a common reason to do it. If they're greater than 40, at 40 we start adding mammography annually. Now, United States Preventive Service Task Force, they have changed the recommendation to at 50, and you get it every 2 years, but most American Cancer Society still endorses at 40 annually, and almost all care providers continue to use that guideline or that recommendation. At 45, you add a lipid profile every 5 years. At 50 is when you do a colon cancer screening, and so that actually needs to be updated, the slide here. So at 50, colonoscopy screening. Now if they elect not to do colonoscopy, you can start fecal blood testing every 3 years. At 45 would be better. And at 50, TSH every 5 years. At greater than 65, you add a bone density every 2 years in the absence of any new risk factors.
And I think we'll see this done more frequently, but actually if their lipid profile is normal at 45, they don't need another one until they're 50.
Yes.
That's the recommendation.
Yeah, so 5 years.
Every 5 years.
Yep. Okay, counseling. Talk to them about contraceptive options, including emergency contraception.
And we covered that in pharmacology. The recommendations for breast exam, we know that breast self-exam is not recommended. I have some women who do it religiously. I don't routinely offer that. If they ask me, I give them the information and teach them how to do it.
Yes.
Information about menopause and information about abuse. You should ask every woman about abuse at every visit. That's the recommendation. Tanner stages, we'll talk about secondary sex characteristics, and those are graded based on Tanner staging. And there's a Tanner stage for both males and females. So for female breasts and genitalia, and for male genitalia.
And hair growth. So you'll see the hair growth associated with the areas, of course, of puberty that you would expect and what the hair would look like. So you need to know both for a woman, the breast and the hair growth, and for the men, the genitalia, their penile or scrotal enlargement, and the hair growth as well.
And I'm going to guess that your Tanner stage development information in your text is in the adolescent chapter. And so you need to flip forward to that adolescent chapter because that is fair game for this exam.
Yes.
And so here's another graphic representation.
So 1 is what you're born with.
Yes,
That's,
what you're
that's
born with.
easy. And 5 is always full adult development. So it's just really 2, 3, and 4 that you need to be able to distinguish from. So, 2 for a woman or for females is breast buds. So that's the very first of breast development or breast buds. And for a boy, it's scrotal enlargement. So the scrotum enlarges before the penis enlarges. So that's stage 2. In stage 3 for a female, you get overall growth of the breast. You can see not just the buds, but now I always called it the cone boob because
It's still one
unified, but it's just kind of cone shaped, if you can see. And then for the male, they start getting both penile, that's when the penis first starts to enlarge. And then stage 4 for the female, I call this the double boob because you have a little differentiation between the areola and the rest of the breast. So you have that difference. That's how I remember it. So the breast buds, the cone boob, the double boob, and then the adult boob. And then for the male, you see both further growth and start seeing that hair develop more so.
And so, of course, I'm feeling uncomfortable. I'm not allowed on the couch. And so, of course, when a woman comes in for a genitalia exam, they're uncomfortable. You're going to be up close and personal in their very personal space, and they're going to be naked, and they really don't know you that well, probably. They may only see you once a year. We have a lot of women in our practice who elect to stay within our practice for their well woman care. They don't really want to go somewhere else. They don't want to be a number. They don't want to feel herded, and they don't want to have to sit with all the pregnant women, that sort of thing. At the same time, we have other women who prefer not to have the same person that does everything else do their genital exams. And I think it's important that you let people know it really doesn't matter either way. You just want them to be cared for. So if you feel more comfortable going for somebody else, I have 2 nurses who would not let me do their pelvic exam for $1 million. I have one nurse, she hollered at me one day, "Hey Bobby, come here." I walked in and she's naked up on the exam table. She said, "I need you to do my pap right fast." Okay. So she clearly doesn't care. Just we had a 5-minute window. She ran in, shoved her scrub bottoms off, and hopped up on the table, and off we went. So,
That's awesome.
and it doesn't hurt my feelings
For you
either
not
way.
being a pet person, I really like that.
Yeah.
That's cute.
Yeah.
Um,
So again, this will promote anxiety. We need to be comfortable to talk about some sort of weird, wonky things. You're going to get a few women who like to do this, and you're going to be a little concerned about them. But as a general rule, they dread it like the plague. I had a woman today who showed up for an annual PAP, and I think she was 45, and she only needs one every other year now. And so the girls talked to her and said, "You really don't have to have a PAP today?" I walked in the room, she was like, "Oh my gosh, you're my new best friend. I always knew I liked you, but I don't have to have a PAP today." That's pretty much the classic reaction.
Yeah. Ensure gentleness, make and maintain eye contact. One thing I didn't mention yet, but she always does, is she always meets with the patient with their clothes on first.
Absolutely.
So before you have them undressed, don't let your nursing staff, your MAs or whatever, whoever puts the patient in the room for you, don't have them undressed before you get the opportunity to go in and sit down and talk to them with their clothes on. It just makes them feel a lot more comfortable. I know that makes a difference for me.
And I know in a lot of women's health offices, folks are undressed before the provider gets in there. I just have been blessed that I have never had to be that busy that I couldn't step in, address any concerns that they might have, go see somebody else right fast while they're changing clothes. They just appreciate it so much more. It really doesn't take any more time.
And then you can really get a better history because they're not, fidgeting with
the paper drape. I mean, who wants to wear a paper towel? And that's what it is these days. So if you're doing a lot of women's health, you should not wear warm clothes in the winter. You should wear short sleeves and a lab coat so that you can keep your rooms a little warmer because they're going to be naked and they're cold. Make sure that your room is situated so that the exam table doesn't face the door, so that when they're in lithotomy position, if somebody opens the door, their entire world is not visible to the hallway. Make sure that they have the opportunity to go to the restroom. Just some basic things that you might not think about.
Yes.
When they're in lithotomy, they're blind. They're like a turtle on their back. And literally, in some older, obese women, they can't get up from that position by themselves.
You have to help them.
And you just, if you do it the same way every time, one of my nurses tells the patients, you'll never find anybody do a faster path than her. I have a system, and it just flows, and I can get in, get done, and get out. There's no need to dilly around in there.
That's true.
With patients who have never had a PAP before, I do what I call show and tell. And so I basically take my Mayo stand, and I really just kind of show them, this is your vaginal vault, this is the speculum going in, and show them everything I'm going to do so that there are no surprises. And like even the click of the speculum can be concerning if you don't know what that is. So I tell them, you're going to hear the speculum click, and that's not you cracking, that's the speculum. Just so, and then inevitably when that speculum clicks, they kind of giggle.
They do, yeah. Make sure to put your gloves on.
Yes, yes. And some people put 2 gloves on their dominant hand so that they can do a rectovaginal exam. If I have somebody who's doing colonoscopies, I don't do that. I always tell them, because this is the way I was taught. I learned how to do PAPs and pelvics with what was called GTAs. I thought I was going to forget. Gynecologic Teaching Associates. So 20 years ago, these women quasi-volunteered to be patients to teach us how to do pelvic exams. At that point in life, they were paid $35 an hour. There were 4 of us to 2 of them. The first person was the horizontal teacher, and the other one was the vertical teacher. And so this first horizontal person, there were 2 students who did a pelvic and a PAP. Then we all stepped out because we all watched. Then they traded places, and the other 2 of us did a PAP and a pelvic. So somebody just had to be first, somebody just had to be last, and somebody had to be second. I ended up being third. So I was the first person to do a PAP and a pelvic on this new horizontal person.
Yes.
She had genital piercings. There was not a dry thread on me.
Oh my gosh.
I was nervous as a cat on a hot tin roof just doing a pelvic for the first time. Then I had all this jewelry that I needed. I was scared to death I was going to rip out some of this jewelry with the speculum because I'd never held one before.
Yeah.
But this is basically what they did, and they knew what it should feel like, and they could tell, sort of like we tell you with ears, it's in a little too far, or you're pushing a little too much on my canal.
Yeah.
They kind of told us that.
That's good. But they taught you, you'll feel with your hands on my knees, and then your thighs, and then your bottom. So you're preparing them, not just going right in for the kill. Exactly.
Absolutely. Look at never underestimate the value of inspection. Look at their external genitalia. Look at their labia majora. Look at their labia minora. Look at their urethral opening and their clitoris. And so this goes through that. We can kind of click.
Then you separate the labia majora with the non-dominant hand to inspect the labia minora. Palpate for that.
You can look at the clitoris and urethral orifice. You can look at the vaginal orifice.
Skin glands and the
Bartholin glands. You can see Bartholin gland abscess. So again, that's going to be in that 4 to 5 and 7 to 8 o'clock window. And it'll look like a ping pong ball or
you might have pictures of it somewhere.
a golf ball in there.
Yes. Google it if you haven't seen it before. You need to
Bartholin gland abscess.
It's incredibly painful.
You might have to lance and drain if you're in an environment where you're comfortable doing that, or refer for lance and drain.
They almost always recommend testing for chlamydia or gonorrhea because it's a lot of times associated with STIs. But it doesn't have to be. So there are some women that it's not associated with, and you can get that. They can put a stent in. Did you mention that?
Or a
drainage?
wick, yes.
A friend of mine had a stent put in.
Just to keep that
Just to
open.
keep it.
Otherwise, it'll seal back up and it won't
and
drain.
it has to drain.
And it has to drain.
Mm-hmm.
So these are varying anatomic representations of the vulva, and none of us look the same. Skinny vulva, obese vulva, distorted vulva. Here are some piercings, and so that is very common. I saw this a lot when I worked in the health center. We have a lot of older patients in my practice now. I don't see this so much anymore. This is pretty much what I saw when I got ready to do my first pap and pelvic. So you can see why I was a little nervous. I just knew this ring at the distal aspect of her vaginal opening was going to get pulled out with that speculum. I was so nervous. So you can, as a novice, you can insert one finger into their vaginal vault to try to locate their cervix so that you know about where you want to put the speculum. I rarely do this. There are some other sources that say you can put the speculum in, and if you can't find the cervix, you can pull it out and then put your finger in to try to find it, and then go to try to find where their cervix is. I'm usually...
You can find it. If you get practice enough at doing it, you can usually find it without the finger technique.
You can evaluate for any cystocele,
which is where the bladder is bulging into the vaginal vault. A posterior bulge is a rectocele, where the rectum is kind of bulging into the vaginal vault.
and cervical prolapse, where the cervix is either in the vagina, at the introitus, or external to the vaginal vault.
First, second, or third degree.
And if it looks normal, tell the patient.
Yes.
Again, they're sitting there wondering, I wonder what's going on down there. I surely can't see anything. And so you can just say, everything looks normal so far.
Reassure them.
And so we talked about this, how you can insert that finger to try to find the cervix if you need to. Make sure that you kind of play around with the specula before you do your exam. And we'll have a specula for you in class so that you can sort of see how it works. We use disposable specula in my clinic. You do too?
Mm-hmm.
Some OBGYN offices still use metal.
Like Cape Care for Women?
Because they invested in them a long time ago and they're paid for. So it's going to be an added expense for them to transition to disposable. I have a nice halogen lit.
Yes, I love that halogen.
Oh my gosh. If you're going to play this game, you need the good toys.
Oh, yes.
I never use lubrication. It can alter the pH of your vaginal vault. So I really never use anything. They say you can use a little tap water, but I never really have to do that. We talked about at that 45-degree angle toward the small of the back. You sort of want to go in from a 45-degree angle to the side toward the small of their back, and then sort of sweep up until you see that cervix. And then you're home free, because that's really what you need to see. So here's both a metal and a plastic disposable specula.
With the metal one, you actually have to tighten. You're gonna.
They're harder to use,
harder.
I think.
Yeah, because with the plastic ones, they click in place. You literally just squeeze it, and it clicks, and you don't have to tighten. You don't have to.
And you can sort of see this area right here, where once you click here, it holds right there. And I never honestly use anything other than a small specula.
Yeah.
They make them in all sizes.
No. Yeah. Smaller the better for the female. For
Absolutely.
Sure.
So otoscopes, we use the larger the better, but for vaginal, the smaller the better.
Here's
So-
some more pictures of the different types and sizes.
Mm-hmm.
Now our small isn't this small.
That's actually a pediatric.
Okay, ours is like that one,
Mm-hmm.
but it's plastic. So I guess it's the one.
Yes. And so this is how you can hold it. Again, you would have to push down on this lever and then screw that down to hold it open. So it really is a two-handed process where a plastic disposable only requires one hand. So here's an image of the speculum in the vaginal vault, and you can sort of see it encircling that cervix so that you can collect cells from that cervix for a pap smear, because that's what you have to have for a pap is cervical cells. So we're looking at the cervix. It's usually pink, midline, it's smooth. If it has discharge, it's usually clear, and the os or the opening usually slit or circular.
And the os will be different if it's Paris or non-Paris. So if you have a non-parasitic, never had children before, it's usually, again, more of that slit or smaller opening, whereas a paras will have a bigger opening.
So to collect a pap smear, you want to collect cells from the cervix, and there are a variety of options. You can use a device that sort of looks like a pipe cleaner. You can use a device that sort of looks like a broom, or you can use a device that looks like what we call a spatula. And they are either plastic or wooden spatulas.
It's called spatula. It doesn't look like a spatula like what you use for cooking, though.
No.
It's got kind of rounded
edges. We've got a picture coming up to show you a spatula. But in a perfect world, it's 4 to 5 days after the menses. I can tell you that I have done them at the beginning of the menses, and at the end. People have a hard time getting off work. Oh my goodness, I started my period. You can just sort of take a large Q-tip. Some people call them a rectal swab, but don't ever call it that in front of a patient when you're going to put it in their vagina, because they don't know where it's been. So it's just a very large Q-tip, and you can sort of clean their cervix off and sort of absorb most of that blood and then get a few cells and send it off. No douching, don't put anything in your vagina. Ideally, no intercourse for 48 hours prior. There's that large Q-tip. If you're going to evaluate for chlamydia and gonorrhea, you put a special cotton-tipped applicator that is particularly for chlamydia gonorrhea testing, and you put it at the os. You leave it there for 30 to 60 seconds, and you rotate it 360 degrees, put it into special solution, and send it off for evaluation. And so if you're evaluating somebody 25 years of age or younger, they probably need chlamydia gonorrhea testing, and or if they have had multiple partners, new partners, and or have symptoms. And so what I tend to say is I'm going to put this Q-tip right at the opening of your cervix. This is the one that I told you that needs to sit here for 30 to 60 seconds. We've got about 15 more seconds, so I try to talk about something in the meantime to help that time go a little faster. Turn it and send it off for evaluation. And then we collect the pap smear cells, and I'll tell you what
most don't collect it on the slide any longer. Most send it in a little jar,
it's called liquid-based prep.
Thanks.
So this is a spatula, and it's either wooden or plastic, and you can see that it's sort of curved to fit around the os of the cervix. I think of the cervix, I think it looks like a powdered sugar donut, one of those miniature powdered sugar donuts that the hole doesn't get poked out of, only it's pink and shiny.
Yeah, that's good.
I think that's what the cervix looks like.
It sure does.
This is the pipe cleaner type brush that can be used, and this is really good because you can get endocervical cells.
So if you're having trouble getting to that transition zone,
You need this.
Yeah.
And I let them touch it so they can see that it's kind of soft.
Yeah.
And then here is what's called a broom. And so the broom, it
has a point in the center, so it gets into
those
that
bristles
os.
go in that endocervical space.
I typically will use a brush like this and also the pipe cleaner if I need to.
Yes, I always use a pipe cleaner.
Yeah, you can always guarantee that you're gonna get the transformation zone that
With the pipe cleaners.
Yeah.
We talked about chlamydia gonorrhea culture, so we've already done that. Then samples for vaginal microscopy.
So this would be important if someone was complaining of vaginal discharge, odor, those kind of things. Sometimes itching. Yes. So if you think that they may have a yeast infection, bacterial vaginosis, or trichomoniasis, you would do this, and you can use one of the 3 swabs to evaluate the pH, and then you can test for potassium hydroxide. Put some sodium chloride on it, or hydrogen peroxide.
And there's a great table on page 569 differentiating trichomoniasis from candidal infection, vulvovaginal candidiasis or VVC, and bacterial vaginosis. And here's sort of an algorithm that guides you in determining what might be the problem and how to treat it for the patient who presents with symptoms of vaginitis. And then there's also a great article
Link there.
And then you want to make sure that you close the speculum before you remove it. If you remove it with the blades open, it's going to be very uncomfortable for the patient. So close that speculum, and sometimes, as Michelle said, you sort of have to back it out a little bit to release that cervix, then fully close the blades, then come out. You also want to let them know that that part of the exam is over, and now you need to proceed to the bimanual exam. So now you're going to put some KY jelly on 2 fingers of the dominant hand. Insert that into the vaginal vault, and then you want to take your non-dominant hand and put it on the middle of the abdomen to try to trap the uterus between your fingers, and then on either side, palpating for those adnexal structures, those ovaries and tubes on either side. Again, in most women you will not palpate ovaries.
And they will feel firm pressure, but they should not really experience pain with this. If they do, that's an abnormal finding. And we talked about, I think we talked about chandelier
sign and cervical motion tenderness already. So when you palpate that cervix, you think about how large is it, where is it located, what's the contour, the consistency. Here's cervical motion tenderness and a chandelier sign related to PID. And it's going to feel weird, but it shouldn't be painful.
Yeah. So you do need to know chandelier sign and cervical motion tenderness, that they're go hand in hand, it's the same thing, and it's associated with pelvic inflammatory disease.
For whatever reason, when we talk about the pregnant uterus, we do it in terms of fruit. I don't know why. But
all kinds of things.
Yes, about 9 weeks is a peach, 10 weeks is an orange, 12 weeks is a grapefruit.
I remember when I was 16 weeks, you're an avocado, and I had a little picture with my avocado.
Okay. At 16 weeks gestation.
I think that's what it was, 16. Palpate the adnexa, noting the right and left ovaries. Are they firm, smooth, ovoid, slightly tender? Again, you are unlikely to actually palpate the adnexa or those ovaries. But again, if you're feeling in that area and you do palpate one, I would be concerned, especially if it's tender or seems larger, especially if it's asymmetrical.
Then you need a pelvic ultrasound.
Yes.
For sure. Rectovaginal exam, again, if they're up to date on their colorectal cancer screening, I absolutely don't do a rectovaginal exam. But you let them know you're going to insert 1 finger into the rectal sphincter and 1 finger into the vagina, and the whole purpose is to sort of trap that rectovaginal septum between your fingers and you're sort of evaluating the integrity from the side. You want to have them sort of relax and bear down. I don't know. I'd rather have colonoscopy as have this, quite frankly. The cul-de-sac, and then you can also evaluate if they're over 40 guaiac. I always give my patients some sort of tissue to clean up with because
the KY jelly goopy
is nasty. It's just nasty. I don't use a lot of KY jelly. Like, you know, I see those people who put I put like
just
a dime size on my table, and then I just put enough.
Yep. Just to kind of coat your fingers so they go
a little dab will do ya.
Exactly. They don't need a whole lot.
So tell them what you found. Discuss how you're going to communicate any test results to them. Can you leave a message on their home phone? Would they rather have it on their cell phone? Will they access it through the electronic medical records system? Can you send them an email? Do they have any questions? We know about monthly breast exam and how that's no longer recommended. Let them get dressed, document your findings, then you can always come back and see if they've thought of anything else now that they have their clothes on. Here's how we can document the results.
Although we wouldn't say WNL, we don't document external genitalia within normal limits.
Right. I want you to actually tell me what you see, and there's an example of documentation in your textbook. This has to do with how you send your pap for evaluation. Historically, and some of you may never have seen this, we used to take the cells that we collected, smear them on a slide, spray them with fixative, put them in a case, put your name on it on a piece of masking tape because we recycled the cases, and send them to the pathologist for them to look at the slide. The problem with that is that they only get one slide. So if there's any abnormality, they're going to read it as abnormal, and then you're going to have colposcopy,
Exactly.
which is $800 to start
And a lot more.
if they have to do a
invasive.
biopsy,
Exactly.
and another day off work.
Yes.
If we do liquid-based technology, where we take those cells from your cervix, we suspend them in liquid, sometimes called thin prep, that's one of the
Thin
brand
prep.
names,
Yeah.
and we send that off to pathology, they can prepare multiple slides and look multiple times and say, oh, well, I had this one little abnormality here, but I did 10 other slides and they were all normal. And then we don't have to refer to colposcopy nearly as often.
Yeah. More accurate. Cervical cytology screening, American Cancer Society and American Colleges of Obstetrics and Gynecology, is that how you say it?
Obstetricians and gynecologists.
Thank you.
Yeah.
They recommend that cervical cancer screening begin approximately 3 years after a woman's first sexual intercourse or age 21. These just change. Is that still the case?
Yes.
Okay,
This
so
is-
that's still a
We
cause.
used to say
Yes,
at
yes.
first intercourse,
Mm-hmm.
or like at age 18,
18, whichever came first.
whichever came
Yes.
first. And now they really say pretty much nobody needs it before age 21.
Yeah. Yeah, I know when I was 18, we were still in the old guidelines.
On the, yes, and I think these came about 3 years ago. I'm going to look right fast here.
Yes, it was about 3 years ago, I think, was when those changed.
ACOG PAP guidelines.
So these recommendation slides, I believe, have they been updated this next?
Women aged 21 to 29 should have a PAP test alone every 3 years. HPV testing is not recommended. Women aged 30 to 65 should have a PAP test and an HPV test, and they call that co-testing, every 5 years. It's also acceptable to have a PAP test alone every 3 years, but co-testing every 5 is preferred.
Preferred. Okay. So the next couple of slides we'll go through quickly because they are not
Up to date.
up to date with that recommendation. So, all right, a fly in the wind.
Regardless of the frequency of cervical cancer screening, annual pelvic
Yes.
exams are still recommended.
So this is where it gets a little tricky. They think they don't need a PAP, so they don't think they need a pelvic exam, but that's actually not true. They still need the pelvic exam. They just don't need that actual lab of doing the PAP smear.
Right.
Screen.
Yes, anybody 25 years of age or younger, regardless of marital status, should be screened for chlamydia because oftentimes in women they are asymptomatic and they are at an increased risk of infection, particularly if they've had multiple sex partners, if they've had sex with somebody with multiple partners, if they have had intercourse with an individual who has been proven to have an STI, repeated episodes of STI, or if they just show up at an STI clinic.
Yeah.
Just showing up there says you're at risk.
There's actually a code for high-risk sexual behavior
Mm-hmm.
that we use a lot of times with this kind. HIV, ACOG recommends screening those that are at high risk. So if they've been seeking treatment for STIs,
So if you have chlamydia, you need to be HIV tested.
yes. If you're seeking, or if you're drug using, any IV drug use, history of prostitution or having intercourse with a prostitute, past or present sexual partner who is HIV positive or bisexual or injects drugs, long-term residents or birth in an area with high prevalence of HIV infection, and history of transfusions from 1978 to 1985. Bobby can talk about that a little bit. Your husband actually works for a company now that...
Yes, so between 1978 and 1985, we did not have efficient, sensitive, or specific eradication of viruses from blood products. And so my husband actually works for a company and they have FDA approval in this country they have a product that actually inactivates viruses in platelets. So HIV, dengue fever, Zika virus, chickamauga virus, all of those, if the platelets are treated with my husband's product, they're eradicating those viruses, and it's in trials in Europe to be used on whole blood products. So yes, it's the American Red Cross just adopted the technology, so it'll pretty much be standard of care. There's been an article in the New England Journal of Medicine advocating for the use of the technology, and now it's just sort of down to money and people incorporating the money into their budgets to be able to adopt the technology.
Invasive cervical cancer and any and all women that are seeking evaluation prior to conception.
And the CDC now recommends routine HIV screening of adults, adolescents, and pregnant women in healthcare settings in the United States. So basically, everybody needs to be tested at least once, and then depending on your lifestyle and your risk.
How often after that?
And there's actually now a program called PrEP, pre-exposure prophylaxis. And so for those individuals who engage in risky lifestyles and are at risk to develop HIV, so particularly males having sex with males and IV drug users, there's actually a program that whether you like it or not, we're paying for it, where they can start taking antiretroviral therapy as prophylaxis for the development of HIV. It's called PrEP, P-R-E-P, you can look it up. Cervical cancer, worldwide 500,000 women die of cervical cancer every year. Now certainly in the United States our numbers are much lower.
Click here, there you go.
Oh, I was behind a slide. And we know that once we started screening women with pap smears during World War II, the number of cervical cancer deaths declined dramatically. We also now know that about 98% of all cervical cancer is directly related to human papillomavirus, and specifically about 4 high-risk subtypes of the virus. There are some 60 subtypes of human papillomavirus, and we'll really only care about 4 to 6 of them. And so if you have genital warts, you need to be screened to know, do you have a high-risk subtype or a low-risk subtype? So we know that, I think I just told you everything on this side. Gardasil, there are now a couple other branded products for human papillomavirus. It is a vaccine that can help actually prevent cervical cancer, those high-risk subtypes, 6, 11, 16, and 18. It is now indicated in both boys and girls. This is administered just like hepatitis B vaccine. So today, 2 months from today, and 6 months from today.
Here's some more links for that. And again, that link for vaginitis. Thank you.